failure, especially heart failure with reduced EF. So you can see in this figure from a JACC publication, sort of the annual event rates for ASCVD. The very high-risk patients have a 7% annual event rate. And when you look at heart failure, even the most stable populations have minimum 10% yearly event rates. And how do we get that down as low as possible? And some of these therapies maybe are key to that. So let's start with a case. So we have a 77-year-old man with heart failure with reduced EF, presents to the clinic with persistent dyspnea exertion. He's sort of a new diagnosis. 8 months ago, ischemic cardiomyopathy, his EF is 20%. He had undergone PCI to the LAD, but he does have substantial residual disease in the circumflex and RCA. He had a very complex cardiac surgery with a LV pseudoaneurysm, which was resected, and then he had an alveoli stitch to correct his MR. He does not have any further revascularization options, but he has persistent NYHA3 symptoms. He does not want any further procedures, including an LVAD. He's only on an SGLT2 inhibitor and an MRA at low doses. He can't tolerate RAS inhibitor or beta blocker therapy due to dizziness. You see his blood pressure and heart rate are low and high respectively. He's eulemic on exam. His renal function's normal by creatinine, but he's pretty frail, so he may be a little bit reduced in his GFR. And his NT-proBNP is quite elevated despite being eulemic. And so a question for the audience is, what medication or medications could you start to help his symptoms and reduce his risk of heart failure hospitalization? I'll show you his echo before that. Quite a sick heart. And so I think the answer to this question is there's two medications that would be appropriate in this patient, but I'll make an argument for why digoxin may be the best approach for this patient. So this was a trial that came out this year, is presented at ESC. It's the digoxin in patients with heart failure and reduced ejection fraction trial, the Dixit HF trial. And the background behind this trial is that the DIG trial in 1997, it missed its primary outcome, which was death, with a hazard ratio of 0.99, but cardiovascular hospitalizations were numerically reduced 0.87. Back then, they were using death as a primary outcome, not they weren't, composite endpoints were not as common in heart failure trials. And as we'll see, there were better outcomes noted in the lower digoxin level subgroup, 0.5 and 0.9. Digoxin is a related cardioglycoside. It has better hepatic excretion, less renally excreted. It's not FDA approved in the United States, but it's almost the same thing as digoxin. And just a review of what digoxin does, it has kind of two mechanisms. Stimulates the NAK exchanger, which leads to increase in potassium levels, which increases contractility in the heart, but at the same time, it increases vagal activity, which slows down AV conduction, reduces heart rate, and so it's sort of a positive inotrope without a positive chronotropy. The Dixit HF trial looked at HFrEF patients that were on stable therapy for at least 6 months. EF was less than 40% with NYHA3 symptoms, or EF less than or equal to 30% with NYHA2. They couldn't be on a cardiac glycoside, and importantly, there's no exclusion for renal dysfunction unless there was also liver dysfunction. And the dosage is for digoxin 0.07, and there's a target range here, which is equivalent to kind of that 0.5, 0.9 for digoxin. And the comparator was placebo, and our outcome was composite of death or heart failure hospitalization. So kind of off the screen here, let's see if we can get it on. So the 1,200 patients, large portion of them NYHA3 symptoms, two-thirds NYHA3 symptoms. You can see pretty good medical therapy. This is just when SGLT2 inhibitors are coming on. It's 3/4 on MRA. Quite a few patients with at least mild CKD, GFR less than 60, and almost 40%. and sort of the summary of that is it's a medium-sized TEP-REF trial with symptomatic patients on good background medical therapy. So our primary outcome of death or heart failure hospitalization was reduced with digitoxin. It's an 18% relative risk reduction, 5% absolute risk reduction at a median follow-up of 36 months. And you can see the endpoints, while not secondary endpoints are not meeting significance on their own, they're reasonably consistent with the primary outcome. Death is 0.86, heart failure hospitalization 0.85. You see the Kaplan-Meier curves for death sort of diverge and then reconverge towards the end. Same thing with heart failure hospitalization. When we look at subgroup analysis, patients with higher heart rates and lower blood pressures benefited the most. So you can see there's some heterogeneity in both of these. GFR didn't really matter for benefiting, nor being on any background therapy you want, triple therapy, quadruple therapy. And there were few adverse events leading to discontinuation and equivalent between digitoxin and placebo, and just one episode of dig toxicity. And most of the patients, whatever dose they were started on, they were continued on throughout the trial. So I think this sort of begs the question, is digoxin underused currently? As you can see, when we started heart failure trials, in the 80s, 95% digoxin use. Most recently, less than 20%. And there's some reason behind that. We have much more therapies for heart failure, but I think we'd be remiss if we didn't review why digoxin was so popular, 40 years ago. And so this is some of the early trials with digoxin, and looking at the hemodynamic changes and hormonal changes with 1 milligram of IV digoxin in patients with dilated cardiomyopathy. And this is at rest. You can see with digoxin, at 6 hours, their heart rate goes down, their cardiac output goes up, their wedge pressure goes down, their norepinephrine levels go down, along with renin activity, aldosterone. So you get an increase in cardiac output and decrease in wedge, and actually a decrease in sympathetic and RAS activity. And this is consistent with exercise as well. And you can see actually the hemodynamic impact of digoxin is actually similar to dobutamine at 7.5. Like, that's a sizable dobutamine dose, and you get very similar increases in cardiac index and decreases in wedge pressure. But again, you don't get that stimulation of the neurohormonal system. And this kind of broke down who are the responders, who are the non-responders. The responders had higher heart rates and higher wedge pressures and lower cardiac index. So those are the ones that responded to digoxin versus the non-responders were sort of more compensated patients. And then this is sort of looking at PO digoxin. It's very similar impact that you get with IV digoxin, just a little bit less so. But you still get increases in your index, decreases in your wedge, and when you withdraw with digoxin, your index goes down, your wedge goes up, and you get exercise benefits as well. And this is the dose that they were using in some of these studies. It's a reasonably small dose, the level of 1.1. Some of the early trials showed that it improves exercise tolerance. Digoxin patients maintain their exercise duration during the study, while placebo patients, they got worse. And then when we look at the DIG trial, that sort of the main trial that sort of people looked at to say digoxin wasn't effective, this is all-cause mortality, this is placebo in the middle. If your level was high, you actually had more increase in mortality. But if your level was low, or kind of in an ideal range, you had a decrease in mortality. This is in the DIG trial. And if you look at heart failure hospitalization, substantially lower compared to placebo in the digoxin concentration of 0.5 to 0.9. And so we know that keeping that level within that ideal range may be beneficial for heart failure patients, and I think Digit HF reinforces this with digitoxin. And I think we can apply this to digoxin as well, especially if we can keep that level in this ideal range. And I think that's most easily done by using low doses. If we get digitoxin, that might be helpful because it's more hepatic excreted compared to digoxin. There is an ongoing digoxin trial, Decision, which will look at a similar population but with digoxin. So I think the takeaway is in these heart failure patients with persistent symptoms, and especially those with high heart rates, low blood pressure, low stroke volume patients, digoxin may improve symptoms, reduce risk of heart failure hospitalization, get that positive inotropy without that neurohormonal stimulation. Just real quick for ivabradine, that would also be a reasonable option in this patient, but maybe doesn't quite get the same symptomatic benefit that they might get from digoxin. But this is the SHIFT trial 2010, and ivabradine in heart failure patients that had elevated heart rates despite max tolerated beta blocker, they had a decrease in the composite endpoint of cardiovascular death or heart failure hospitalization, hazard ratio 0.82. So similar to what we saw in Digit HF, and patients not on beta blockers and had high baseline heart rates, they benefited the most from ivabradine. So this patient also may benefit from ivabradine. Whether you could use both digoxin and ivabradine together, there's not really a good study to answer that question. But if you had limited options for a patient, it may be reasonable. Victoria, which is vericiguat, 2020 trial. Importantly, the patient I presented in the beginning had a very high NT-proBNP, 8,000. So this actually patient potentially not benefit from vericiguat. And in the Victoria trial, the highest quartile of NT-proBNP, they actually had worse outcomes with vericiguat. So as we'll talk about in a little bit, vericiguat may not be the best option for these advanced patients. And so we have our 4 pillars, and then you start to consider these per the guidelines of ivabradine, vericiguat, digoxin as sort of adjunct therapies for heart failure with reduced EF. So we'll go to our next trial. So here's another patient. It's a 52-year-old man with Lamin related cardiomyopathy. He's coming for routine follow-up. He was diagnosed 6 years ago. His EF has been stable for 40%. He had monomorphic VT 3 years ago, and he has an ICD. He has NYHA2 symptoms. He's relatively stable. He's on good medical therapy. He's got sort of normal exam. His potassium is 4.0. Creatinine is 1. His ICD interrogation, he has multiple episodes of NSVT and 1 ATP therapy. So what is the best next step for this patient? Start sotalol, increase spironolactone to 50 milligrams, and then initiate KCl supplement if potassium is less than 4.5 or no changes to his therapy. So I'll argue that you should increase his spironolactone to 50 and then try to get his potassium to a minimum of 4 or 5 if possible. And we'll talk about this trial as the reason why I advocate for that. So this is increasing the potassium level in patients at high risk for ventricular arrhythmias. This is the POTCAST trial. And so this asks the question, so why are we doing this trial? So potassium levels in observational analysis of 4.5 to 5 are associated with lower mortality in patients with CV disease. Patients with heart failure with reduced EF are obviously high risk for ventricular arrhythmias. 5 to 10% event rates per year of ventricular arrhythmias, and these account for half of the deaths from patients with heart failure. And so the POTCAST trial looked at patients with ICDs or CRTD, that was sort of mandatory for inclusion, and a baseline K of equal to or less than 4.3 and a GFR greater than 30. And what they did, very simple, just try to get the potassium to high normal, 4.5 to 5. And they used either supplements or MRA therapy or both. And they also tried to reduce diuretics. They started with every other week visits. So it's quite intensive to obtain the target K, and then every 6 months once they were stable. This is just compared to standard of care. And their composite endpoint was sustained VT, ICD therapy, or hospitalization for arrhythmia or heart failure or death. Baseline characteristics, most of the patients had ICDs. The mean EF was 45, about half had reduced EF less than 40. Baseline potassium level was 4.01, so not super low. Most would look at that and say that's a normal potassium. And then most of them had VT previously. And this is what they're on at baseline. Some are on both MRA and potassium supplements, but most are actually on neither. And then what did they end up on? Most of them ended up on both MRA and potassium supplements in the intervention arm. So this is the adjustment in the potassium level when we try to target that high normal range. So you can see most of them actually didn't even get into this target range, but there is a shift of the curve, by a little bit. So it starts at 4.0, the placebo is at 4.0, or the control is at 4.0, and they shift up to 4.3 with the intervention. And so it wasn't a huge difference in the potassium level, but as we'll see, there was a difference in the primary endpoint. So just increasing the potassium level from 4.0 to 4.3, it led to a decrease in the primary endpoint, 0.76 hazard ratio. This is the primary composite endpoint of ICD therapy, death, hospitalization for arrhythmia or heart failure. It's 7% absolute risk reduction, 24% relative risk. Number needed to treat of 15. It's a pretty low number needed to treat. And you can see it's quite consistent across the endpoints. Hospitalizations for arrhythmia and heart failure, 37% decrease in these endpoints right there. And you can see the Kaplan-Meier curves right here. So more benefit was seen in secondary prevention patients and patients not on MRA at baseline. So see the subgroups that benefited most. If you had your ICD for secondary prevention, you benefited a lot. So the patients that had a VT episode already, they really benefited. Patients that weren't on MRA therapy at all at baseline, they also benefited a lot just from probably the initiation of MRA therapy. So our conclusion from this trial is increasing the potassium level is effective in reducing adverse events related to ventricular arrhythmias in patients with ICDs. It supports targeting that 4.5 to 5 potassium level if you're able to monitor closely. But as we saw in the trial, most of the patients didn't even get to this level, but just trying to get it higher, not being sort of content with the level of 3.9, 4.0, 4.1. That shows that you can get benefit just from getting them up, 0.3 MEQ. And if you, especially important for patients with prior ventricular arrhythmias and no MRA therapy at baseline. And so try to target that range if you can. Use MRAs, and thiazides and loop diuretics, they deplete your potassium, so you can discontinue them. That's a good idea to discontinue if it's not needed. Here's our last case, 68-year-old Asian woman with chronic heart failure. She's coming to the clinic. She's been on stable GDMT. She has EF of 35%. She's on 4 pillars of GDMT. She had an ICD implant 3 years ago, but it was complicated by device infection and removal, and she elected not to have it replaced. So she doesn't have an ICD anymore. Here are the labs, and what medication may reduce her residual risk of death. And I'll argue that it may be vericiguat, although I will acknowledge the data is a bit weak on this, but we'll see why it may be suggestive, and we may not get another trial to look at it again. So this is the variciguat in patients with chronic heart failure and reduced ejection fraction, the Victor trial. So the Victoria trial, which I had mentioned earlier, that was 2020, it met its primary endpoint, composite endpoint, and that was in high-risk heart failure patients. But the effect of variciguat in more stable heart failure patients is unknown. But as I said in the first slide, even the lowest risk HFrEF patients have substantial residual risk of hospitalization or death, combined 10% annually. How does variciguat work? It's a guanylate cyclase stimulator, so you get more guanylate cyclase activity, more cyclic GMP, and then there's theoretical benefits across multiple organ systems, decrease in inflammation, vasodilation, renal blood flow, things like that. How it exactly exerts its effect in heart failure to provide benefit, not quite known. So the Victor trial, HFrEF patients EF equal to or less than 40%, NYHA2 symptoms or greater on optimal GDMT. These are stable patients, no hospitalization in the last 6 months or IV diuretics in the last 3 months, and their NT-proBNP had to be at least a little bit elevated, but not too elevated, between 600 to 6,000, GFR 15 or more, and it was variciguat titrated at 10 compared to placebo, and usual kind of endpoint CV death or heart failure hospitalization. So our baseline characteristics, so most of the patients had either not had a hospitalization in a year, or they never had a hospitalization for heart failure. So quite stable patients. They're on very good background medical therapy, 4 pillars of GDMT. So the trial was actually negative. It did not meet its primary endpoint. 0.93 was the hazard ratio, p-value of 0.22. But why it may be important is our endpoint of cardiovascular death, 5.7 versus 6.8, is a numeric reduction because the primary endpoint is not met. 0.83 hazard ratio, 17% relative risk reduction. Hospitalizations, 0.95, recurrent hospitalizations, 0.90. But again, the event rates, of all-cause death in this population, 14% in the trial, 8.6 per year. So I mean, there's still sick patients, despite not really being hospitalized much for heart failure. So why may variciguat be useful in this population? There may be a differential effect on the secondary endpoint. So these are stable patients in terms of they don't really get hospitalized as much, and so maybe variciguat doesn't exactly reduce the heart failure hospitalization endpoint, but potentially it may reduce our cardiovascular death endpoint. As you can see, the separation of curves there. When they looked at sudden death rates, they were reduced, exploratory endpoint, but significantly reduced by variciguat, and heart failure related deaths, exploratory endpoint, but significantly reduced. And if you pool these two trials together, Victoria and Victor, there is a significant 9% relative risk reduction in the combined endpoint, heart failure hospitalization and CV death. So variciguat is a possible adjunct. It may provide modest benefit, reducing both CV death and heart failure hospitalization. And I want to compare kind of what the three we just talked about to our heart failure therapies established 4 pillars of GDMT. You can see the rates of heart failure hospitalization more modestly reduced by digoxin, variciguat. Potassium level actually increasing it may reduce up to 35%. And mortality, nothing really compares to the 4 pillars of GDMT, but potentially we get a little bit extra from digitoxin, variciguat, increasing our K level. But the idea is the cumulative together these kind of all add together to reduce that residual risk as low as we can get it. So these are kind of the takeaways of the three. So when you use digoxin, we don't have digitoxin in the US. Think of these low stroke volume patients, high heart rates, low blood pressure, EF is less than 30, they're persistently symptomatic, they're not tolerating GDMT, the GFR has to be 30, and they have to be reliable enough that you can get the dig level and monitor and get in that 0.5 and 0.9. Targeting that K level of 4.5 to 5, especially important in our high-risk VT patients, not on MRI therapy. You start the MRA, and they got to be reliable and able to monitor the potassium level. Varicequa, it's still a bit unclear where this population, who that population may be, and I don't think we'll get another trial to look at Varicequa. So you wouldn't be wrong not to use it ever, but if for a patient that really wanted everything, maybe a stable patient with residual risk of death or sudden death. So the patient that presented in the beginning, she didn't have an ICD, and maybe she's higher risk of sudden death without that ICD, potentially maybe amenable to Varicequa. Higher risk patients with persistent symptoms with their NT-proBNP has to be less than 6,000. You may get a little bit of benefit from it, but I'll say it's the weakest drug out of the ones we talked about. I have some extra ones I can breeze through if you want to hear. So Maple HCM is aficamten versus metoprolol for obstructive HCM, and so really quickly, you have symptomatic obstructive HCM patients, so they either did aficamten, which is a cardiac myosin inhibitor, plus placebo, or metoprolol plus placebo. So it's really an aficamten versus metoprolol trial. The outcome was a change in the peak VO2 on CPET, and the baseline characteristics of the gradients were quite high, like 70 with Valsalva. And the results, there was a significant improvement in peak VO2 with aficamten, and really the notable thing is the patients on metoprolol, they felt worse actually. So their peak VO2 went down, and then their gradient actually really didn't change with metoprolol. So metoprolol basically did nothing for these obstructive HCM patients, whereas aficamten was quite beneficial. And so, I think when we look at our obstructive HCM guidelines, they want you to use these cardiac myosin inhibitors after beta blocker or calcium channel blocker. But when you look at actually the citations that they provide for this support, it's very small, weak trials. There's really no high-powered evidence. And one of the biggest trials for beta blocker therapy was 29 patients. And that's what has been using to support the guidelines. So I think what we can take away is that that this trial really showed that beta blocker therapy doesn't really improve the gradient and worsens VO2 max. And I think it's reasonable to try it first, but I wouldn't expect a huge benefit of beta blocker therapy in these patients, and you would see a large benefit with the cardiac myosin inhibitors. Mavacamten is the one that has been FDA approved first, but aficamten is FDA approved now and should be on the market shortly. Here's another trial, which is I think pretty practice changing. It's the RiverWar trial. So it's rivaroxaban versus warfarin in LV thrombus following MI. And it's a randomized trial in Pakistan. And we looked at rivaroxaban versus warfarin for these post-STEMI patients, and the primary outcome was 3-month clot resolution. So these all STEMI patients, low EF, randomized right after ACS. This is the INR level of the warfarin group. It's all over the place, which I think is reflective of our experience too. And you can see it's small, but the rates of clot resolution at week 12 were the equivalent, and actually the Xarelto group, they resolved their clots sooner than the warfarin group. And there's other small randomized trials. If you meta-analyze them, there's no difference between DOACs and warfarin for LV thrombus in this setting. So I think overall, I'm going to use DOACs in this population and not use warfarin anymore because it's just way easier to use DOACs. I don't know if you guys talked about trilipidine 2 already.
I think it was mentioned, in the structural heart.
So trilipidine 2-year data. So I'll just go to the results. So the 1-year trial, obviously, there was improvement in KCCQ, but the hard endpoints were not very convincing. But I think one thing to look at when you look at the 2-year data is cumulative heart failure hospitalizations were reduced in the device arm. And there was a lot of crossover from control to device after the trial ended. So, take that, it's controversial, but I think for certain patients, there's not really much you can do for severe TR, and so, a tricuspid valve clip, may be beneficial, may reduce hospitalizations, although the data is a bit weak. And then poly-HF, this is polypill and HFrEF. The full manuscript's not out, but basically the overview is if you do a polypill of beta blockers, spironolactone, SGLT2 inhibitor versus just standard of care, do you get an improvement in LVEF? And the answer is yes. So there was 3.4% difference in LVEF by using this polypill strategy, and it's really driven by adherence. Polypill they were more adherent to heart failure therapies than usual care, and then there was also better optimization of the doses in the polypill arm. So potentially, if we get a polypill for heart failure, it may be useful for patients. That's basically it. Thank you.
Great. Well, thank you so much. Just a few questions from the audience. Do you have any questions?
It's interesting to hear your take on it. There were all those observational trials that came out like 10 years ago that were like making pretty extraordinary claims about like single dose exposure, of digoxin was actually increasing. Some of them had like hazard ratios of 1.2 of mortality, right? Like the ACC even put I think some of that came out of some of the DOAC trials. Even there were patients, they were looking at people that were randomly on digoxin. They found this weird trend towards mortality. They were not observational trials.
Yeah.
The ACC put out like a whole big blast probably about a decade ago that basically said avoid digoxin. That is again largely for atrial fibrillation and not heart failure.
Right.
But
I think that is probably confounded because those patients that are on digoxin probably are sicker patients. They try to adjust propensity matching, but that only goes so far. But generally the digoxin patients are sicker, like harder to control heart rates. So I think when you look at the randomized data, which it's limited, but the randomized data is reassuring, especially when you can control the level, which in my experience, when you use lower doses, start at a low dose, and then if you have to go up. I think when I've done that, I've not really run into high levels. And if anything, I've run into low levels and had to increase. So I think it's not unreasonable to use it, and now that we know high levels are bad. We've known that for a while, but I think we have better evidence to suggest now that there's benefit overall.
So one question I had for you, a couple questions. First of all, so we're now encouraging use of digoxin, but at the same time we're also increasing the potassium. We're encouraging increasing potassium. So if you have both of them, do you not have a little bit of a danger of DIG toxicity? Obviously not at, 4.5 or 4.3 is what the trial looked at.
Mm-hmm.
But there's, obviously if you go above 4.5 or much above 5, over 5, is there not an increased risk of DIG toxicity? So using both, and I saw the graphic where you showed that there was so much better improvement with use of potassium, like normalizing potassium, and then also the DIG was amazing, the effect on mortality. So I feel like, okay, if we're going to encourage both of them,
Mm-hmm.
what is your thought about, like, where do you?
Yeah, I'd have to look at, because also hypokalemia
Is also bad.
Yeah, and I'm trying to remember the association with digoxin and hypokalemia, but it may be good to avoid that combination too.
As
So
well, yeah.
that may offset some of the risks that you may get with hyperkalemia and digoxin. So I think I think the big takeaway is if you see a potassium of 3.6, 3.7, often it doesn't highlight as red,
Right.
and we just kind of leave it. But now we have evidence to say, maybe we should push it a little bit higher, and
that's great.
that I think is an easy sort of fix, and you don't necessarily need to monitor like as intensively as they did. But I think they were just trying to prove the concept, and I think once you know the concept, you use it in clinical practice what's reasonable for you.
Yeah, no, I thought you brought up really excellent points, and these trials were very. I thought they were very useful because this is good for all of us in clinical cardiology,
Mm-hmm.
and also to some extent primary care, because it's very much easily doable by even our primary care colleagues. So I thought you brought up really good, relevant information. And one other question was, as far as devices, have you had any experience with Barostim?
Not I think Stanford's pretty big on Barostim.
CRX, yeah.
We haven't used it, but actually the kind of mechanism is similar to potentially beta blockers, digoxin, when it's vagal stimulation, and so you decrease your catecholamines, renin-angiotensin system. So I think it probably needs more data. Off the top of my head, I can't remember convincing data, but I think the concept is intriguing, and the mechanism is potentially beneficial.
Yeah, you bring up a very good point. So if neuromodulation is the benefit, would a comparison between digoxin versus Barostim may be useful in understanding better, or would they be actually complementary treatments?
Probably complementary, I would think.
So like if they're on digoxin already and they're still kind of floundering, maybe add Barostim?
Yeah, I think it's hard to say because a lot of times when you have these sick patients, you're trying to find there's a fine line between patients when you're designing the trial, they're too high risk that nothing is going to help them, or they're not high risk enough that these extra interventions, you don't, like we saw with Vericiguat in stable patients, it didn't really move the needle enough. But is that because they're too stable?
They're too stable.
There's just trying to find that right population. I think it's still a bit difficult when we have great therapies already.
Yes.
And so it's tough. I think for patients, I always think about patients that don't have many options. Those are the patients where I want as many options as new options. Like that patient with no revascularization options,
right.
Doesn't want an LVAD, can't tolerate any standard medical therapy. That's the one where I want digoxin, maybe I want Barostim, things like that.
Yeah.
Just things that I can potentially give to help the patient like that.
Yeah. No, I appreciate the thoughtful nature of your presentation. I think it was very practical, and hope to see you again.
Yeah, thank you. Thank you for
Thank you
inviting me.
so much.